Welcome back from the lunch break. Welcome back to the Global Health Talk. I hope you had an interesting discussion over the break and are full of energy back here for the next discussion that will focus on the question, what global health architecture do we need? And the global health architecture has many challenges with regards to the fragmentation, inequalities, funding, and there is no easy answer, I would say. But we have a panel today here, and a group of experts, again, in the Catalyst dialogue, the new format of the Global Health of Germany, has addressed that question: how can we improve the functioning and the structures of the global health architecture? And the discussion paper will be released soon. And today we have the opportunity to have a synopsis, a kind of a preview of the discussion. And we have members of that expert group with us here, and also representatives of the ministries. And I will now hand over to Clemens Gros, the moderator for the session, also the funder of Insights for Development. He has been moderating the expert dialogue and with us, the Global Health of Germany, and partnering with Healthy Developments. And I already hand over to you, Clemens.
Thanks very much, Christina. Welcome back to this afternoon at the Global Health Talk 2022. We do have a fantastic panel for you, and I will introduce our panelists in just a second. And we will throw ourselves at this question of how to build the global health architecture we need. I've heard the global health architecture mentioned this morning a number of times. Christina just mentioned it again. And the words associated with it that I noticed were complexity, fragmentation, maybe a bit messy. This morning I was talking to my 4-year-old son over breakfast about what I was going to do today. And I said, we'll discuss the global health architecture. And predictably, his reaction was, the what? To which I said, so here comes my 30-second elevator pitch of what we're actually talking about. See how this works for you. I said, think of the global health architecture as the world's attempt to try to organize itself in all things related to health. So the global health architecture is meant to help us tackle our common challenges, like making sure everyone, everywhere has access to good health care. Or we don't have major global pandemics closing your kindergarten. And so he says, is that working? Kind of, right? But it is the key question. So is the global health architecture delivering the results we expect from it? And when we think of results, we think of, I guess, quite naturally, the Sustainable Development Goals and what we're meant to achieve by 2030. So on the plus side, on the health-related goals, we have 8 years left to achieve them and made good progress on a number of them. You know, think of reduction in AIDS-related deaths, reduction in tuberculosis deaths, etc. But we're very far away from achieving that healthy lives and well-being for all at all ages by 2030. That's a big ambition, and we're far from it. Plus, we've had this pandemic, which had such devastating consequences and caused so much disruption everywhere. Therefore, I would take these as signs that there's something amiss with the global health architecture. Humanity does seem to have some difficulty trying to organize itself in global health. So how can this be done differently? How can we build a global health architecture that delivers the results we expect? And this was the question put to our Catalyst dialogue process, as Christina already outlined it. So in a nutshell, bringing together 7 bright minds coming from a really diverse field of perspectives, from the private sector, from development cooperation, foundations, and academia, and all joining for a series of virtual discussions, for individual interviews, to harvest ideas and inspiration about what's amiss and how can this be done better, to feed it into the German policy space and to discuss it with decision makers. And this is what brings us here today. So let's welcome our panelists. I'm happy to say that 2 of our 7 Catalyst Dialogue participants are with us also today virtually. So it's my pleasure to introduce to you Kate Dodson, live from Washington, D.C. Kate is the Vice President of the United Nations Foundation for Global Health Strategy. That's her field. And she's currently also serving as Chair of the Board of the Global Health Council. Welcome, Kate. Second Catalyst Dialogue with us today is Elhadj RC, live from Dakar, Senegal. Az is Chair of the Board of the Kofi Annan Foundation, and prior to this, you might have seen him serving as the Secretary General of the International Federation of Red Cross and Red Crescent Societies, IFRC. Welcome, Az, great to see you again. Kate and Az will bring the spirit of the Catalyst Dialogue into this discussion with our distinguished panelists here in Berlin. And with that, I'd like to welcome Mr. Paul Zubeil, who is the Deputy Director General for European and International Health Policy at Germany's Federal Ministry of Health. And prior to joining the ministry, Mr. Zubeil was, among other things, the Deputy Director of UNFPA. Welcome, Mr. Zubeil. And in fact, we said, let's put protocol aside for the ease of the conversation, so we'll go by a first-name basis. So welcome, Paul. Thanks for joining us. And this panel wouldn't be complete without Dr. Bernhard Braune, who is Head of Division for Global Health Policy and Finance in the German Federal Ministry for Economic Cooperation and Development, BMZ, where he also previously served as Head of Division on Return on Reintegration Issues. So let's give all of four a welcoming applause, please. The last word of introduction is that obviously you here in the room and in the live stream are really important participants to this Catalyst Dialogue, to this panel discussion as well. If you've been here for the morning sessions, you know how it works. Please post your questions into the Slido chat that you see next to the live stream window. And even being here in the room, I'd encourage you to go to slido.com and using the hashtag GHT2022 that you see all around the room, post your questions there. It has the great advantage of letting everyone see your really smart and fascinating questions, and they can give you a thumbs up. So when we get to the last third of this discussion, we'll have a crowd-vetted set of really interesting questions. That said, if you're here in the room and you have that, you want to give voice to that really riveting question, then we have microphones here for you, and so we'll make that work as well. So let's start this discussion with a bit of a diagnosis of where we are with the global health architecture, what we're actually looking at and what we're up against. And I'd like to start with our two Catalyst Dialogue participants who are with us today. Az, during one of our Catalyst Dialogue conversations, you diagnosed global health as suffering from, and I quote, promises made and promises broken. And this isn't a new phenomenon. You mentioned going back to the 1970s, the Alma Ata Declaration, some of us might remember, health as a human right, essential primary health care, etc., which is nowhere near to be seen. So given all these broken promises, are governments too ambitious in global health or just not very good at coordinating to get things done? Az. I'll start with Kate then. Maybe Az didn't hear us there clearly. Kate, thinking about what we're looking at with the global health architecture, as part of our Catalyst Dialogue process, it was brought up many times that rather than an orderly architecture, which I as a German would really like, the practice of global health looks more like a really crowded, noisy marketplace that's crowded with institutions and ideas that compete for funding, that compete for attention. And some would say, that's healthy diversity, but others would say, that's fragmentation, which creates inefficiencies. So to what extent is it necessary on the one hand, but on the other hand, to what extent is it possible to introduce more architecture, more order, more coordination into this marketplace to, let's say, organize the chaos and make it effective? Kate.
Well, thank you, Clemens, and I hope you all can hear me and that Az is able to join us again shortly. It's a real pleasure to be with you all, and I'm sorry that I couldn't be with you in person. And Clemens, I think this is the fundamental question that we talked about through the Catalyst dialogue, so I won't do it justice in just a brief set of opening framing remarks. But I do think it is important to start with a recognition that the last 20 years really have been a golden era in global health, where huge progress has been made against the MDGs at that point, and now the starting chapter of the SDGs, reducing the incidence of HIV/AIDS, increasing access to immunization and family planning services and the like. That was because, in part, of a huge investment in the establishment of new global health institutions, new parts of the global health architecture. So have they delivered results? Have they been an important part of the contribution? Institutions like Gavi, the Global Fund, the Global Financing Facility, and CEPI, alongside UN agencies like UNICEF, UNFPA, the World Health Organization, and others? Yes. Undoubtedly, yes. They've made important and vital contributions to the world's progress on global health goals. They've even made COVID response faster, right? The collaboration that was engendered through the ACT Accelerator. But as you point out, as others have pointed out, as we talked about extensively in our dialogue, there is a real lack of both incentives and norms and expectations around planning and coordination of the global health ecosystem, the architecture, as we've talked about. You can think about how this manifests in lots of ways. Among them, for instance, that the ACT Accelerator was only established as the pandemic was underway in April of 2020. We need to further institutionalize the kind of standard operating procedures, forms of collaboration and partnership, financing flows for collaborative efforts like the ACT Accelerator for when we need them against future pandemic threats. So planning and coordination is a vital ingredient and really needs to be enhanced going forward. We also talked about increasing the incentives for collaboration across the existing global health ecosystem. The Global Action Plan for Healthy Lives and Well-Being, which the German government was a big proponent of together with others, was a step in that right direction, a way of saying, listen, these larger global health institutions need to do a better job of servicing the needs and priorities of the countries that they're intending to support. And it went a long way to try to increase that collaboration. But incentives also need to be in place around funding and around accountability and board governance, where sometimes that collaboration breaks down in the favor of kind of silos that also tend to persist in our ecosystem. So if we're going to look at this, kind of play it forward, what this could or should look like, what's a new piece of the architecture, a new piece of the puzzle where it actually could be value add and not increase duplication or redundancy. Think about something like the new pandemic accord, which is under active discussion among governments in Geneva. That's a kind of instrument which is designed to enhance the kind of norms, the standard rules of procedure, the operating options for the global health ecosystem to better perform in the context, in this case, of a pandemic. It also could create higher degrees of incentive, of compliance, of positive incentives for governments to work more collaboratively. And if it does those two things, I think it will be a value add into the global health ecosystem, even though it's already complex.
Thanks, Kate. Oz, if you can hear me, I'd like to, Kate pointed already to a number of things where there's signs of hope and how sort of to do something about making the global health architecture more effective. But to ensure that these are not new promises made that are then being broken, I want to come back to my question of, so are governments too ambitious in global health, given all the broken promises? Or are they not ambitious enough, or just not good at coordinating to get things done? What's amiss here? Oz.
Yeah, thank you. What's the miss? Promises are often made, in middle of crisis, when then we're all in panic, And we, in our first report of the Global Preparedness Monitoring Board, we called it the cycle of panic and neglect that must be broken. Because we make those decisions and promises, which are often ambitious, and they are made in political fora by politicians, and rightly so. We want political leadership. We would like to see the political fora also addressing the issue of concerns for citizens, and global health is one that is, very good. The problem sometimes is that those fora are not always so inclusive. And when it comes to implementation, then the divergences, appear. And those who are not fully on board, who are not fully included, do not feel the same level of accountability and responsibility. And then it happens also at times when decisions are made by politicians in political forums, that changes happen with the changes, of governments and then changes of systems. We've seen that a number of times when very powerful countries, make a very strong commitment, for some global health issues. You have a change of governments, and then the decisions, just simply be reversed. So we see also a number of times, that decisions and promises made, not necessarily just to build an architecture, but to commit on some substantive issues that will make the architecture work. And then there's a lack of adherence to that. The international health regulations, one of them. We see on a more local level, so on my continent, when the heads of governments and states, meet almost 20 years ago to commit to a certain level of investment of their national budget to health. And then 20 years later, with the fingers of one hand, you can count those ones, that held their promises. And then where the accountability? So we don't often have, behind those decisions, a citizen constituency that will drive it and then hold, the governments accountable, with some exceptions, and they are almost the same. Now, HIV/AIDS are the constituency where activism become part of the architecture, and I think some of those things were delivered on, and then we quote that quite often as an example, and many of the fundaments of the global health architecture relate also to that pandemic, and the constituency behind the activists, the people living with HIV that were pretty much, actors alongside the science and then the political leadership that we could, see. We are seeing now a similar process, going on with the climate change and its relations, to health, that show those three paradigms again, that activism, play a very important role. So what is then missing is a kind of a consistency across the board, from the time the promises are made to the implementation, a consistency in the implementation of it, a constituency of a citizens or an activism that will guide and then hold accountable, an empowerment, of the technical leadership, be it of agencies, or other institutions that should not be left, without resources, to implement, something that is decided but not following suit. And then what is really needed is then to have that continuous, commitment and political leadership and continuity. Even I think in the promises and in the leadership when the governments, change, because there should be a slight difference, between the promises of states and the promises of governments. And I think some countries manage, to ensure that others, don't. So the other thing is that still in this cycle of panic that and neglect, that we often see, we miss often opportunities, to create the synergies between the different existing organizations and initiatives, that we create. And the tendency is often, to create another one and add, to the architecture. And then, we will have these different layers of coordination that will be needed. And of course, if we continue that route, coordination will suffer. So there is a bit of everything that you said, I think ambition, yes, but consistency in the ambitions through implementations, maybe not. Coordination, a challenge, because of the multiple additions, that we are seeing. A lack of accountability in most of the cases, and with few exceptions, such as HIV, a lack of constituency of citizens that will drive, that commitment through implementations all the way down to evaluation, and then building on that, as a stepping stone, towards, striving, for more and better. Over.
So Kate and us have given us a laundry basket full of issues, challenges, but also pointers, I think, in directions. So, Paul, in order for us to not be in panic and to be consistent, I think what makes me hopeful on the side of Germany is that Germany does have a global health strategy, right? And Germany invests in many global health initiatives, so it really has influence in many of these places. But therefore, given all that investment, people expect that global health architecture, that investment, to return results, the best possible health for all. Yet again, what the patient receives is not what was ordered, even when looking at just pandemic preparedness and response. So these shortcomings, would you say that's due to shortcomings in global health governance, or what's the problem?
Well, first of all, thank you very much for this really pertinent questions, and also to my predecessors who just outlined many important issues here. First of all, I would like to mention that yes, Germany is a huge advocate for global health, and not only since the beginning of the pandemic, has been a strong advocate for many, many years. And I think if you look at Germany's global health strategy, you can also find this commitment embodied. But yet again, it's true that although countries have committed to reach the SDGs, if you look at, for instance, the triple billion goals, it's very clear that we're very much off track. So the point here is that global health challenges cannot be solved by one country alone. It needs to be solved in a coordinated fashion. It needs to be solved in a truly a partnership approach, not only by countries, but also by multilateral agencies, by civil society, by private sector, etc. pp. So if you look at what the COVID-19 pandemic has caused and what the secondary effect of it is, it's absolutely clear that we need to be far more ambitious than what we've seen so far. But back to the question on the shortcomings of global health governance, if global health governance is to blame, I think if there's one thing that we can recognize and agree on is that the COVID-19 pandemic has really demonstrated and exposed the gaps and the failures, actually, on national, but also on international level, obviously, and we need to urgently correct those. But apart from the shortcomings in global health governance, I think we have a huge issue in pandemic preparedness. I mean, if you look, for instance, in the implementation of the international health regulations on national level, if you look at the institutional capacities of WHO, there is a lot of work to be done. And one aspect why this has come a little bit too late or has not been that far advanced is really the chronicle underfunding of pandemic preparedness, despite all evidence that preparedness is much, much cheaper than response can actually be. And as rightly pointed in the way, we have to break this cycle of panic and neglect. And if there's hope to overcome this, it actually has to be now, because the window of opportunity, while a pandemic is still ongoing and acute, we need to actually tackle it now, because there are many competing crises around the world. Once we're getting out of this phase, you will not find the support of everyone and the buy-in of everybody, and of obviously also not the funds that can then help to increase pandemic preparedness and prevention, and also in that way actually pay its tribute to a good health governance.
I guess what I hear you say, Paul, is that no one is safe until everyone is safe, therefore we need to invest in all these sort of entry points that you mentioned. And one of the entry points that I'm picking up also on a mention in the chat here is countries' health systems. We cannot hope to invest globally and something to trickle down, but in fact it starts at the country level. And global health features strongly, Bernhard, in bilateral development cooperation. And that might sound abstract, what is that at the country level, but in fact Germany supports and works with many lower middle income countries on, for example, health system strengthening the quality of primary care. Yet, 40 years on after Alma-Ata, quality is still relatively poor in many countries. So I suppose my question is, can Germany, as an actor in global health, be satisfied with what global health governance has delivered here, with its own contributions to it, and what it delivers to partner countries? Bernhard.
Thank you. Of course, it's not our contributions that are responsible for the failures, I would argue. No, but seriously, it is, of course, a huge human rights issue that half of the world's population does not have access to primary health. This is something that goes unnoticed, I would argue, outside the circle of experts. And it is a real tragedy. And those of us that are living or have been living in partner countries, implementing countries, know what I'm talking about. The drama of people, children, people of all ages dying because of preventable diseases that here you will fix in half a day without much discussion. That's really a tragedy. And I think that's why it is important that we ask ourselves if the system is fit for purpose. And looking at the results, of course, the answer can only be it's not. The question is, how do we fix it? And I would argue that it's not about the complexity of the global health architecture. It is complex, but I think it's manageable. In my view, it is about funding. And I want to make this point, it's about the individual responsibility of nation governments. They are also in the responsibility to make choices on their budgets even before donors make these choices. So it is not only a question for donors or for international organizations, but it is certainly a question to national governments. That's, I think, why the point of civil society engagement is so crucial. A government, any government, will decide on a budget according to political agenda priorities, and then it's civil society, if it's a democratic society, of course, that can make that point, that it's about providing healthcare for under 5-year-old kids and these priorities. Unfortunately, under 5-year-old kids don't vote, so they do often not have a lobby. That's again why civil society is so important and organizations. But coming back to my thesis, it's not the complexity in Geneva, it's the lack of implementation in partner countries that concerns me most.
And so I'd like to continue our second question round now, focusing on the question you posed, how to fix it. So given these construction sites that all of you outlined, what can be done differently to ensure that the global health architecture delivers results? Bernhard, you already pointed to one of the starting points. But I'd like to start with you, Paul. What do you see as the most important challenges to be tackled first when it comes to building the global health architecture we need?
Yeah, thank you. I mean, let's take a step back. I mean, the global health community had to respond to many challenges over the past decades. If you look back to HIV, malaria, Ebola, just to name a few, as well as natural disasters, crises, and that has led in a way to the establishment of a great number of different stakeholders that also address specific diseases in a very vertical manner. And a consequence of that was that, it was said before, just as a word, basically this institutional fragmentation and the duplication of services that we face, and also, that's a truth, a weakened WHO. So what we need really is to have clear mandates, to have a clear legitimacy, and we need increased coordination, and especially a strong cooperation, and we need to focus. And I think we have made a huge progress, and that was made when it was decided at the 75th World Health Assembly that the Sustainable Financing Group of WHO could consent on it to sustainably finance WHO and make it stronger, meaning having more core contributions, more predictable funding, and enable the WHO to actually build this capacity that they lack. As Germany, we do strive for a constructive multilateralism. We are also convinced that we need a coordinated way of dividing actually the labor based on actual competencies. We have too many actors that are fragmented. We need to actually focus again, and we need to improve existing structures and not constantly create new ones. I think that is in the book and our housekeeping work to do. And we have actually great instruments that are coming our way. I mean, if you look forward, we have the Pandemic Treaty, for example. We have the establishment, just straight up the crate, of the Financial Intermediary Fund. So there are ways of how we can tackle it, and we need to learn from the mistakes of the past. But if I can say, and then I finish, the probably biggest challenge we had and that came out of this pandemic was really the way how we communicate in a trustful way. And it has shown that if trust is not there, it's very, very difficult actually to build a global health architecture, because it can only be with the buy-in of everyone, and trust is one of the key ingredients to that.
And these are, in fact, you're mentioning two issues that were on the top of people's minds in our Catalyst dialogue with our 7 participants. One was fund WHO properly to give it that, or to strengthen the role as the normative pole of global health, or for WHO to provide that collective action context to basically that trustful environment where action can happen. And Bernhard, coming back to what you just said about it has to start at the country level or with national governments. The tricky thing being, as we heard from our Catalyst dialogue participants, that change is always difficult, but it's especially difficult in health because it can be so politicized, not only globally, in partner countries, and in Germany. It will always be more popular to build a new hospital than to fund prevention activities that might lower diabetes rates in 10 years from now. And therefore, what's the right, but also what's the realistic thing to do to ensure that the global health architecture delivers results? Bernhard.
Yeah, it's a complicated question because it is a complicated system, and we need to find ways to make the funding that is available. And Christoph Ben mentioned 50 billion this year. Also want to recall the German contribution to Act A, 3 billion, which saved not only our contribution, but Act A, 15 million lives through vaccination. I think there are results that are there, that are good. Was also mentioned by Kate, the results of Global Fund and other institutions like Gavi. So we don't do everything wrong. That's the positive. But how can we, of course, increase? And that's, I want to come back to my thesis. We need to be looking at country levels. How do we make sure that the funds that are available reach those where it's most needed? And I mean, this is, of course, a general question of development cooperation policy. How do you prevent building only the shiny projects in the capital in comparison to the not so shiny regional hospital far away from public attention? And I want to make my point again. It is about civil society, about democracy in these processes, getting those people that are the beneficiaries or potential beneficiaries, getting them involved. That's why, I mean, there are many reasons why we need to be making that point about creating more democratic structures. But also in health, we see that this is really urgent also when we want to be efficient and effective. And then the democratic process of spending a budget is not something that hampers decision-making, and it's not complicated and let's leave it out. It is an equality standard. And we see that in international cooperation, that this consensus is fading away. That is a very dangerous situation, and therefore we need to be thinking a little bit in broader context, I think, and that is good governance, democratic processes, and then we can also be, in my view, more efficient.
Kate, Paul and Bernhard have mentioned a number of things or starting points at the global level, at the national level, but also a number of issues like accountability and trust that also have featured quite prominently in our previous discussions. Considering all the places where change is necessary and where it's possible, what would you put on the top of the to-do list in terms of global health governance? How can we build a better architecture, and who is it who needs to take action? Kate.
Well, I'll try to respond to this really complicated question, and really eager to hear the feedback from others as well, by both underscoring some of the really important principles that have already been suggested by others, and then, some practical solutions here. So I appreciate especially Bernhard's last point around the kind of orientation towards better servicing country needs. The blueprint's there. Dr. Tedros, as part of his second term agenda as Director General of WHO, called for a radical reorientation towards primary healthcare as a pathway both to universal health coverage and greater health security. And that radical reorientation is the responsibility of all players in the global health architecture who, need to better service quality care and access to care for all populations, especially those most vulnerable. I mean, we think about the areas with highest incidence of malaria, lowest incidence of highest unmet need for family planning, lowest access to routine immunization services. Those are the kinds of contexts where all of us need to better marshal a higher degree of quality support to countries to better meet the needs of those most vulnerable populations while building primary healthcare systems that are more resilient and can better provide, as you say, Clemens, the kind of long-term preventative needs against things like diabetes. So that's a really important number one issue on the world's to-do list. It's not a short-term action, but it is a really important reorientation that needs to happen. Frankly, should have happened already, but needs to certainly be accelerated going forward. I'll also, I think, as mentioned as the co-chair of the Global Preparedness Monitoring Board, there have been plenty of recommendations for how to strengthen the health security architecture, how to strengthen collective capacities, how to strengthen country level and community level capacities for prevention, preparedness, and response. We're at a point where many of those recommendations could wither on the vine without concerted, intentional, and enduring action over the medium term, enduring commitment over the medium term, so we don't get into that cycle of neglect. I fear we're almost at the cusp of it. They're sensible, really important recommendations, including increasing financing for pandemic prevention and preparedness, especially for low and middle income countries. And the new Financial Intermediary Fund, just approved last week by the World Bank Board, should go a long way if it is based on a model that is not just on ODA and is incremental new financing. These various review panels suggested to the tune of $10 billion a year. And if they get the governance and decision-making right, including greater participation not only of civil society, which is a point made by many, but also of low middle income country voices, I think Az made that point earlier as well. We need to also codify some end-to-end solutions on countermeasures. I referenced the ACT Accelerator earlier. That's a really important near-term priority to make sure the world is better prepared for the kind of coordinating effort that it will take to address, what will be commodities in need, commodities that are scarce and need to be better kind of allocated across a global ecosystem. Another key recommendation for many, and I think others have made this, Paul and others have made this point, is that a strong WHO needs to be at the center. There are real practical solutions here, including some really important work done and gavelled in at the 75th World Health Assembly on a sustainable financing agenda, and thank you to the German government for their leadership on that. But that is, to Az's point, it's more of a promise than it is a firm obligation. It will take vigilance on behalf of member states to each other, by civil society holding member states to accountable, so that every time through the next several biennium budget negotiations, member states don't fall behind on their commitment to sustainably finance WHO, to give it the kind of financial security it needs to play its hugely important role in as the global coordinating authority for health. And I think that's a real kind of practical solution and needs to be at the top of the priority list. The last thing that I'll mention is, again, not an easy solution, but one that I think has been echoed by many elsewhere, and I'm just going to reinforce this need to better get accountability right in global health to make sure that it is most accountable to the communities and countries in which our collective efforts are intending to serve. And I really don't think we've gotten that right. I don't think there's an easy recipe for that, but I do appreciate some of the points made by Bernhard, by Az, by others in this regard, and want to reinforce those as well.
So lots of to-dos, and Az, to make sure action is taken. In one of our earlier conversations, you mentioned the importance of leadership, which we haven't spoken about explicitly here now in this conversation. But I wonder, do you see enough leadership in global health governance and leadership in the right places? And if not, what's missing? Az.
I think listening to both Bernhard and Paul, as well as Kate, there was a leadership issue behind. They may not have mentioned the word, but if you talk about trust, it's also about leadership. If we talk about promises made and delivered on or not, it's about leadership. If we talk about also being consistent and then translating the commitments into action in a consistent way, it's about leadership. Even if we talk about the role of Germany, frankly, it's leadership. And but the reason why it is then so important, it is behind each of those very important aspects, that we mentioned. And I just would like to reinforce, some of them. Often when we talk about, the leadership of governments, there is a tendency in global health, to automatically think of donors and then the donor community. And then no surprises that some of these discussions, happen in the G7, G20, etc. But we just should have, the reflex of when we talk about government, that is every government on this planet. And then to start, in those places where the needs are greatest, and that is in the low and middle income countries, the government should not be left off the hook. So I love democracy, and I partly agree, I think, with Bernhard, who was talking about, democratic system. But isn't it sad, to see that sometimes, the health outcomes, are better in those countries that are not seen to be, democratic, and in many so-called democratic countries, well, the health outcomes are just horrible because we do not have, that level of consistency in good governance, in accountability, in citizens, engagement, to hold, governments accountable to deliver, on their promises or to even make the right decision. And then we shouldn't be surprised, of course, if then trust, become, eroded. And if you would like to engage, communities and the population at large, in responding to global threats, sometimes we see a lot of hesitation or resistance or blockages, but because, again, that lack of consistency and the lack of delivery, on the promises. We all agree, however, we cannot shift the whole burden, on the shoulders of those governments alone. That's the reason why we need the kind of partnerships, that are required. And then we have given some good examples of partnerships at the global level we have delivered on. So I worked in many of those partnerships, from the global funds, to the UNAIDS and the like, myself. And of course, we all take, pride on that. But we also have to recognize, I think all of us in there, that particularly recently, we are not really following suit, on some of these very strong statements of we're making. None of us is safe until we all are. Well, we all agree. But COVID has showed us, when it comes now to implement that very strong statement, there's all retrenchment into national boundaries, for a global pandemic. There are export bans, on commodities that are being made. There's competition in accessing even the supplies, that were rare, and then those who were richer then will grab them on the market. And that leads to a situation of today that we have, countries that are getting into their fourth dose of vaccination, and then we have some countries that barely reach, the 5%, of the population vaccinated. And then the trust, and the gaps, between rich and poor, and the inequities continue to be widening. So there is definitely there again a consistency to translate, our statements and our commitments into a reality to show that. One point that has not been mentioned here that I would like to highlight that is relates to very relevant to everything we're talking about. It is not only about, democracy. It's also about not only about trust. It's about peace and stability. So we're in a world also that is quite, shaken and threatened, politically by conflict, and the emergence in humanitarian settings are multiplying in every part, of the world, and we do not seem to equip ourselves, in addressing them, and they come in turn to exacerbate these challenges in global health, that we are seeing. Where are those places in the world, where we are not able to eradicate polio, for example? Well, look at the map and then look at the conflict map, and the answer is right there. Where are those places, where we continue to have, the recurrent, outbreaks of Ebola, and then look at the conflict map, it is there. So we are having now in the middle of Europe, again, a conflict, and, that is continuing to having a ripple effect on every part, of what we consider to be a development and then the well-being of people, from food security and then leading to strengthening gains we made in nutrition, to eventually, the treatment of people living with HIV/AIDS, in some part of Ukraine, which were really a kind of a flagship, program for the Global Fund and then the International Alliance Against HIV and then you name it. So I think we need to also bear in mind the fact that all these issues are somehow interrelated. And because there are often the same decision makers that are in different tables talking about different issues, there should be a need at one point in time, to bring all those issues, together around the same table. That is the reason why global health is also a political issue. Global health is also an economic issue. And I think we need to develop a complex understanding of it, and in order to have a complex response to a complex problem. And I agree with all the points that have been made before. So it is now our responsibility to see how we can bring it together in a kind of an index, that will help us, find the right solutions that will not be contributing to the fragmentations, that is ever growing.
This would be a beautiful wrap to the panel discussion. But before we get to the audience engagement, I want us to have a really brief, crisp round now looking at the role of Germany in all of this. This was discussed at length also as part of the Catalyst dialogue process, and this is part of the reason of the Catalyst dialogue, of feeding some of these perspectives into the German policy space. So what can and what should Germany do to create a better global health architecture that serves us all? And Bernhard, I'd like to start with you. So obviously, very small question. We've heard a lot about sort of the global health architecture, that is complicated, but on the other hand, you mentioned the complexity is not the issue. Looking at how Germany engages in global health, what several of our Catalyst dialogue participants mentioned is the interesting fact that how Germany engages is actually not uncomplex. Like, we have responsibilities and roles distributed across different ministries. Bernhard, your ministry is responsible, for example, for the World Bank, for the Global Fund. Paul, your ministry covers WHO, etc. So given that distribution of roles and responsibilities, what can the Ministry of Economic Cooperation and Development do to advance global health governance or the global health architecture, and perhaps Germany in the broader sense?
Yeah, I think we need to do our homework. So there are three things. We need to seal funding. We need to be looking at global health from a holistic viewpoint, and we need to be well coordinated among ourselves and the federal government. And I think we did a pretty good job in Act A. Colleagues in the room, we have a regular system of weekly coordination. The funding goes through, I think, 4 federal ministries, but under one strategic umbrella. Everybody sticks to the respective organizations they are in the lead for. But as I say, there's a strategic approach on what we want to do. There's a co-lead with my ministry and the Ministry of Foreign Affairs on Act A, and that worked really well. There are other positive examples in our collaboration with the Ministry of Health, where, once more, when we look beyond our, let's say, front yard, but take a holistic view, we see also how we can be complementary in the work. As I mentioned, we immediately focus on the situation in partner countries. That's sort of our DNA. And that's what we can bring to the table of the federal ministries. Think of what that decision does to Burkina Faso as one example. Yeah, not everybody has that priority, but it's ours. So that's how we can work as Germany jointly together with a strong funding. That's why we always need the Ministry of Finance in these negotiations. And colleagues there were really open to this economic view on prevention is less expensive than the cure, and coming in with a cure right up front is better than fixing things later. This economic argument was very compelling to colleagues in the Ministry of Finance. That's why we include them up front and very early. And I think that led us to become one of the largest contributor to the Act A in the fight against COVID-19. If we replicate that approach, I think we can internationally play an even stronger role. And then I think it doesn't matter so much what ministry is sitting in the first row, but if it's backed by the federal ministry under also the global health strategy that we have, then the German government is fighting above the weight limit and not below, as we often say. Thank you.
So I can already see there are some concrete to-dos and takeaways from this, which we will get to maybe in a different conversation. But Paul, the same question to you. So what can the Ministry of Health do, particularly to advance, to strengthen the global health architecture or make it a more effective marketplace?
Yeah, thank you. I can only underpin what Bernhard has said, but maybe just to add on this. I mean, Germany has shown a very strong political leadership in the global health arena. I mean, if you look back, global health was high on the political agenda in the G20 already back in 2017, in the Council presidency, and now also in the G7, obviously. So I think Germany is perceived as a very reliable partner for many different reasons. One is, and that Bernhard just mentioned as well, is our strategic approach to the health strategy that is really based on coordinated action, but also our way of how we are doing business. We are in very close cooperation with all other ministries once we talk about global health and global health architecture. So it also shows that we get the necessary inputs and perspectives from different ministries to come to a common position. Then we obviously have, as one of the G7 results, the Pact for Pandemic Readiness, which will be a very good tool going forward, and a number of different other common initiatives, if I think, for instance, of SEEK or any others, and the engagement with non-state actors. So I think we have already a fairly complete package, and obviously this format here today is also just a sign for that we take this topic very seriously, and we like to engage with a multitude of partners.
Thanks. Now, I'd like to put that same question to our Catalyst dialogue participants. Now, these were the government gentlemen speaking, and we've heard in our previous conversations other ideas, similar ideas partly. So, Az, I'd like to start with you. What would you put on their to-do list? Or let's say, what can be Germany's biggest contribution in terms of advancing the global health architecture? Az?
Well, I think they have put enough themselves on their to-do list, and I don't have much on it. So, but more seriously, I think if we had a critical mass of countries that were doing the same as Germany, we would certainly be in a better place. So, and I mean that very honestly. And one of the reasons, again, is here leadership and continuity in state commitment. So at the end of Mrs. Merkel's term, well, I can give you a perspective of the world. We're saying, oh my God, werden wir das noch schaffen? That was a motto. And then people say, okay, will that really continue to be the kind of a commitment and then the drive, on global health, on migration, for example, and many of the issues that we're, worrying about. So it was a kind of a relief and a sense of, I think it was Paul who was saying it, that, reliability, in a country and in a government, in a state, to continue, even if it's a change, of leadership. And I think that is a good basis, to build on. And then the other point, which I think was really appreciated from at least, my perspective and then the place I'm living and then looking at issues, is this reaching out, to others to be involved, I think, in the process of discussions. I used to say that well, with all due respect, the G7 are 7. But I think under the German presidency, we've seen, reaching out, to the G20, inviting on other issues, the chair of the African Union, he was the president of Senegal to discuss other issues, and then the involvement of private sector and having debate, with civil society. All of that, I think, are good practices, that we've seen happening. I don't know enough about, how they organize themselves, between ministries, but it seems to be at least working on a global platform of what we are seeing and what we are receiving. Again, here the challenge is always, to be consistent, to continue to deliver and to engage in the longer term to deliver on those, promises and those commitments. And what we've seen so far are very good, steps and then leadership, from Germany, which we would hope will emulate other governments, not only rich ones again, from middle-income countries, from low-income countries, and then fellow G7, to follow suit, so that we are very honest, about, the road that we have to travel. We are very much mindful of the achievements that we make, but we just don't satisfy ourselves with them, but we use them rather as a stepping stone to continue to strive to do more and then to do better. Over.
Kate, the same question to you. Thinking about all that Germany has at its disposal as an actor in global health, what can it do to play a more constructive and effective role in global health architecture? Kate.
Thanks, Clemens. And I'll try to be pithy in part because colleagues on the panel have already said such really important points. But I had 4 points, and they all build from strength already. As just mentioned, Germany is kind of a mainstay in the global health ecosystem, one with a steady hand and strong leadership already. So these are building from that strength. The first is that Germany should continue to be a bridge builder to forge coalition and consensus. It should insist on inclusive decision-making tables, including the needs and voices of especially least developed countries, small island states, others who don't have the same kind of muscle, diplomatic muscle or otherwise, in multilateral policymaking fora, as well as civil society and community voices. Second, Germany should continue to prioritize global common goods and global public goods for health, including through the work of WHO. Germany sent a hugely important signal over the course of the pandemic, especially in 2020, when the US government chose to withdraw from WHO of the vital importance of a steady hand, including the kind of normative, technical, global coordinating leadership of WHO. Third, Germany should deepen its commitment to health considerations in policymaking fora that aren't just the World Health Assembly or Global Fund or Gavi board meetings, including, for instance, when addressing climate urgency, conflict mitigation and humanitarian response, economic growth strategies, and even, for instance, the chronic and kind of accelerating spread of mis and disinformation, which is a transborder problem in the world. So how can Germany contribute to solutions in those policymaking fora that advance global public goods, global health considerations? The last is to continue, as we've already talked about many times before, to continue to show vision and leadership. Germany's done that many times over. And this fall, we'll host the Global Polio Eradication Initiative financing moment. What kind of vision could Germany inspire for a true global public good, which is a world free from polio? I'll leave it at that.
Thanks, Kate. Fantastic. I'd like to wrap it here for the panel discussion part, but before we come to our great audience questions, so I already see a number of fantastic ones have rolled in, I would like to acknowledge the 5 Catalyst Dialogue participants who you didn't see on screen today, but whose contributions were really tremendously enriching to this conversation, which, by the way, is condensed into a short briefing paper which will come out in English and German in the very near future, so watch this space and watch the website of the Global Health Hub Germany where that will appear. But so I do want to acknowledge someone who you've already seen this morning, Christoph Ben, the Director of Global Health Diplomacy at the Jaap Lange Institute. You saw him at the first meeting. We also had Roland Göde, who is Chair of the Board of the German Health Alliance, so private sector representative. Anna Holzscheiter, Professor of International Politics at the Technical University Dresden, Ilona Kickbusch, who many of you know, of the Graduate Institute of International and Development Studies in Geneva, and Jean-Olivier Schmidt, Head of Program for Backup Health at GIZ. So they were very much part of this Catalyst dialogue, discussing with Kate and Oz many of these important questions. So I just wanted to say thanks very much to their contributions as well. Now, let's turn to a fantastic set of audience questions. And I'd like to, in fact, start by the one that's received also the most thumbs up, as I can see here on screen, which is about this issue of preparedness and prevention. So the question reads, preparedness is better and cheaper than reacting, but prevention is actually better and cheaper than being prepared. But why is prevention no priority? I have an inkling what the response might be. Does anyone want to take that on first? Feel free. Bernhard, please.
Well, there was much debate about the prevention paradox. We do not see prevention. If nothing happens, there's nobody to applaud. That's a little bit the cynical approach, because it's not true. What you see is good health systems. You see community health workers that can detect infectious diseases, for example. And I think that's also part of the solution. You need to make the success of prevention, you need to make that visible. So we come back to the topic that was mentioned also earlier, communication. And I don't mean our sometimes boring government brochures. You can be sure when you mean that by communication, it's not being read by more than the 50 people that we handed out. It's my experience, unfortunate experience. No, but it's, seriously, it's making prevention visible. Vaccination is a good example. I think, nobody sees that as a element, or many people don't see that as a element of pandemic prevention, but of course it is. And we need to be proud of our little yellow vaccination booklets. Yeah? There was a campaign on that, but again, there can be better maybe ways of communicating that. That would be my answer to a complex question.
If anyone else wants to come in, just raise the finger. But else, and if there are questions on the floor also, then please just raise your hand and we will fold you into the conversation. And someone with a microphone will come to you. If not, so there's a fantastic set, and I continue here with the next most popular question, which is how can we enable gender equality in a new global health, that's a big one, in a new global health architecture, including enabling women leadership. Kate, you wanna take that one?
Happily,
being a woman leader in global health.
Well, I already came off mute anticipating that I could make a comment here. I also am a proud board member of Women in Global Health, which I think has done a lot to shine a light on the lack of gender equality in global health leadership. And in fact, in some instances, a real erosion of that progress. We saw, for instance, at the World Health Assembly this year, fewer female heads of delegation than we did the year prior. And it's stubbornly been stuck at only a kind of a dismal third as a maximum of female leaders of global health delegations. And this is a really chronic challenge and problem that plays out at community and country level, that plays out at regional level and at global level. We all know that the global health workforce is overwhelmingly female. About 70% of health and care workers are female, and for the most part, radically undercompensated, especially female health workers, and subject to violence, subject to lack of mobility, upward progress as professionals. And so it starts there. It starts at valuing the health and care workforce in a greater and more intentional way, investing in them, investing in upskill and training, investing in care and safety, so that female health workers who are the front line of all of the issues that we've been talking about here are better and justly supported. And I think then it also comes with a form of accountability that an organization like Women in Global Health is really driving towards, which is, demonstrating that there is a lack of gender equality in leadership. Without gender equality in leadership, we're leaving half of the world's brightest thinking behind. And that's a real shame for all of us.
I hear you. Yes, that's fantastic. So before we take the next question here, could we have a microphone for the gentleman in the front with a red scarf? So we take an audience question here from the floor.
Christian Griebe, nur Tierärzte ohne Grenzen. My question, sorry, English. My question for Veterinarians Without Borders, my question would be, let's assume we build up a global health architecture which is perfect. But I think even then we might face problems of the people who we need to engage with this architecture when it comes, for example, for surveillance of emergent infectious diseases. And this is something where I see you're working in Eastern Africa, so we have a lot of zoonotic diseases affecting livestock. We have that also with the wildlife. And we introduce systems where we have community animal health workers on the ground. We even convince sometimes county governments to report. But what we face then is if we report that one as a state, for example, to WHO, you always have disadvantages. So livestock is not moving, you having the question of compensation, things like that. So the question here is how we can convince also like the pastoralists, the farmers, but also the county governments, even the national governments in these countries to be part of a surveillance system which really is functioning, despite of the fact that we have maybe the technical tools and other things in power, but we don't have the willingness to support it. So there is no, as we know it from the One Health, no added value for them to contribute in that system. And I think that is really a challenge and might be even one thing, if we not find a solution for that one, the best system is not really suiting us good. Thank you.
And this is, in fact, you're raising an issue that also someone in the Catalyst dialogue mentioned, that in all things, I mean, and in health especially, local decision makers need to see the benefit, the return on a decision they're making. Is there someone who sort of has, I guess there is not really an answer to this, but sort of
Just a comment.
An attempt. So you want to come in? Yes, please.
Yeah, just a comment. So the colleague was saying the best not work if it doesn't take into account. Well, if the architecture does not take into account the community dimension, it is not the best architecture. So I think that is the starting point. So any disease, so pandemic or epidemic or outbreak, it starts at community level and it will have to end at community level. And that is, where it has to be understood. That's where it has to be fought. How to understand it? Well, it has to be detected. And I think most of the time, there is, wherever there is a formal system, there is a community system at the same time. I think in the last years, with the Ebola outbreak, there is a development of a community surveillance systems, because these are the community people who first, realize that there's something not right going on. They may be seeing, more animals dying, than before. They may be seeing, going to more funerals, than before in the same period of time. They are the ones, that are seeing that more people are falling sick. And, if we have to break, the chain of transmission, it happens, right there. I think the early involvement of communities, in the detection, in identifying where the risk areas are, and also the involvement, in the response, which is often very difficult in many cultural settings, is very critical. And that will bring us back, that all what we were discussing before, without going into the details, when we're talking about building the trust really with the communities, and then between the decision makers and the communities, between the formal and the informal systems of health and governance, that is, we will not get into that results we would like to see. So I think his question is more widening the base or getting more clarity on what is a architecture means. Architecture means they need a foundation, a very strong foundation, and that foundation is right there at the community level.
Well, did you want to come in on that?
Yeah, as just greatly explained already, but maybe just in addition, we have, not we, but the WHO has the Epidemic Intelligence Hub in Berlin that was just inaugurated last year, and that will also, not in its entirety, but in part, look exactly at those questions. So, and I think it's a very good question, and right after that panel, there will be another panel, you can ask exactly these questions, and also the Pact for Pandemic Readiness that is coming will also have an element that is addressing the question of surveillance and also community outreach. So maybe a little bit patient, so I don't want to take the answers up front, and just to add on to this. Thank you.
Thank you. With that, I think we can take the first and the third. I think, Christian, your question was the third on our Slido panel. We can take that as answered, so we make some space here on our screen for the other questions that are moving up. I'd like to take the second one here. We had the first, Carolina's question. We also can take that as answered. The second question here is, from the audience, when building the global health architecture we need, how is the aspect of decolonizing global health taken into account in this discussion? Bernhard.
This question probably goes to me. I would, first of all, it's really an important question, because we see in so many situations that our history is haunting us, and that we need to be, I think also in Germany, more open to discuss our colonial history and be more aware. We have this tendency, this ended 1918, and it didn't. So that would be my first part of the answer. We need to be open to look at the issue. Second part then, of course, is how do you overcome that history and or the issue. And it's something that we would answer with partnership and dialogue on level playing field. In international cooperation, it's not the donor who has the solutions. It's the partner country, the implementing country, as we sometimes say, and that is the first and only step to decolonizing also global health. It's looking into country owned and country developed solutions, and then being part of that system, of that approach of working jointly on a solution. And that's why I want to reiterate my point on democratizing societies. That can only happen, in my view, in a society that is more or less democratized. It's never 100%, but if you are not open for these dialogues also within the country, then that's very difficult to reach also international. That would be my take on that.
Thanks, Bernhard. If anyone else wants to come in, just jump in. Else, I suggest we take, if there was...
Well, I think, I can't resist but to say one word on decolonization. So, I think, honestly, decolonization is not a gift. That is something to be, fought for. That is something to be wanted, and that is something, to acquire, I think, through your efforts and your commitment. I think there wouldn't be any people up there anywhere outside of, the countries to decolonize, global health. It is, up to, those countries, particularly those with the greatest needs and with a certain history, that we all know, to put in place, the systems, that are required, have the leadership, that is the right one, have the engaged, citizenship, that will also be fighting, for their rights, at a country level, first, so that decisions, are made, towards, the satisfactions, of the needs and then the rights, of the people, and then take it then at another level, so that you have the credibility, to get that, enforced in all the international areas and in the partnerships that will be built, with other countries. And again, it can happen in a democratic, process. Absolutely, that's what people want. But it is also something that should be continuously, fought, because my only bemol, on this, so-called many of the considered democracies, particularly in the global south, is that well, people have the right processes, of elections, and people get elected and think that the job is done, and the job is really starting the day after, which is about now the satisfaction, of the needs and the rights, of the people. And that is a continuous, battle in a positive sense. I mean, a continued citizen engagement and an affirmation of citizenship. And I think that's where decolonization starts, and that will be giving it the credibility at the global level.
Thanks, Oz. So being mindful of time, but also acknowledging that we started a few minutes late, I suggest we take a last round of questions before we're going for a break. And in fact, so I love all the questions that are there, and I think we had one more. Let's take one more question from the audience, and we pair that with one question from the chat. So if we could please have the microphone to the lady, Christoph, sitting like 3 rows behind you. There you go. Yes, please.
Thank you. Sonia Diaz, representing the University of Freiburg, but also representing Colombia, developing country. When I saw the discussion panel, Building the Global Health Architecture We Need, I was not 100% sure about this, the title, because when I see Paris Declaration for AIDS Effectiveness in 2005, I can see that we have all the principles are there. Ownership of the countries, alignment, harmonization, achieving results, accountability. So my impression coming from a developing country is that perhaps the structure is there, but the problems and the challenges are more around how to implement the principles, how to make sure that we evaluate the results, that institutions are accountable, and particularly that we work in a harmonized way. So this is my recommendation. Perhaps we evaluate the architecture that we have next time. And once again, thank you so much for this lovely discussion. Thank you.
So I suppose the question is, don't we already have the architecture? Isn't the implementation missing, if I hear you correctly? And I'd like to just to give you the option on which question you come in, because I love the 2 ones we have there on the voted to the top. One is about Act A, the Act Accelerator, being portrayed as a positive example, while this person says it objectively failed to reach its own goals. It diverted attention from other sustainable technology transfer, for example, the TRIPS waiver. And third, it hasn't been independently reviewed yet. So that's another how come, it's a comment. And the do no harm in healthcare from a German government perspective, what are the areas where instead of doing good, the government could rein in its own harmful impacts, for example, regarding trade and economic interest? I think these are also the 3 of them, fantastic questions. So I give you the choice, the menu, whichever one you want to come in on. And maybe from our participant in the audience, it would be fantastic if you could reflect on, so do we have already the architecture? Is it just the implementation missing? So Bernhard, I start with you, and I give everyone sort of a 1-minute opportunity to come in.
1 minute, okay. I think I said that I thought Act A was positive, and maybe that question is a comment to what I said. And of course, not everything is perfect, far away from making that statement. But let me say what I find positive about Act A. First of all, it is a matrix structure. So we did not create out of panic a new organization, but Act A combined the most important, maybe, or largest global health institutions and put it under one strategic umbrella and one strategic budget. And that was quite something. Then Of course, the budget, we can come with the negative aspects, was not fully paid up for by the donor community. But still, to have that system in place, I think is a really big step forward. That's why I say the architecture itself may be fragmented, but if you approach it in a right way, if you create a coordination structure, it can function. Were the objectives reached? Not all of them, that is true, but they were also very ambitious. We have to keep that in mind. So, you know, if the objectives, it's this discussion of is the glass half full, half empty. I would argue it's half full because we did manage to organize a lot of budget for Act A. Now, the third question, did it not draw away too much attention from other health challenges? Yes, also true. We see that in many areas. HIV/AIDS is one example, malaria, others. But my question is, how could we have acted differently? It's maybe a question to historians, yeah, but I think the shock was so deep that it was unavoidable that we had consequences in other health areas. And on the TRIPS waiver discussion, I waive on that question because it's a bit complex for 3 seconds.
Paul, you want to come in on any of these great questions?
Yeah, maybe just to Act A. I mean, the question we should ask ourselves is also where would we stand now if we had not had Act A? And if, in a sense, yes, not everything is great. It was the first time that this was established, but there are pillars as well that function very well. And I think, yes, we have to acknowledge that there is room for improvement, and Bernhard just outlined those. But I don't think it's right to only criticize this mechanism and see the negatives. I think there's a lot of positive in there that leans really to the good that was achieved. Yeah, on the elephant in the room, on the TRIPS waiver, I also cannot further comment on this at this point in time. But I think I would leave it at that and give the floor to the audience.
And Kate, is there any one of these questions that you want to come in really briefly for like the last 1 minute we have before I turn it to Oz for the final?
Sure, just super quickly. I think the point made from the audience is a really great one. We have the blueprint. We've got principles. We've got, a sense of how the global health ecosystem should work to best support country and community needs. And we have a fairly well-developed set of norms and expectations of the different roles and kind of and comparative advantages of different players in the global health ecosystem. What we spent a lot of time talking about, but maybe not enough talking about in this discussion, is where it fell flat, right? And some of that is about politics and geopolitics, right? We didn't really talk about geopolitics at all in this discussion, but I think it is a real key lesson of this pandemic is that, it not only takes really strong leadership, but it takes an ability to navigate, but also be aware that geopolitical and political influences will weigh heavily on decision makers' decisions. Had a conversation with a high-income country representative, a year and a half ago, who said, well, if not for this pandemic, what did we design the TRIPS waiver for? And why wouldn't it be a no-brainer to actually deploy it in this context? Why has it taken 2 years of negotiation to get us to even just where we are now with the WTO ministerial of a couple weeks ago? And that comes down to politics and geopolitics. It comes down to the fact that norms and expectations are alone insufficient. And I think that then just comes back to the point that all of us have made. The global health community needs forms of greater accountability to the kind of communities and stakeholders which we're kind of designed to serve. And we need to better get incentives right for the kind of collaboration, the kind of addressing root inequalities and more inclusive decision making than we have now.
Oz, maybe one last minute for you also, if you want to come in on any of these.
Thank you. One point, let's not be shy to talk about, TRIPS. And the discussion on TRIPS is not only about waiver, it's much larger than that. So I think we are really shying away of even discussing provisions that already exist, within the TRIPS, with something like compulsory licensing, where it is possible, differential pricing, where it is possible, parallel importing, where it is possible. All of that are provisions, within the TRIP that we, consider the discussion almost as a taboo, that we don't even dive, deep into them, to flesh out what could be done. Back, in the early days, of HIV, some of you may remember that even before the antiretroviral drugs, some of the initial drugs we had were costing $20,000 per patient per year, and they were not the most effective way. Well, Kofi Annan at the time convened the pharmaceutical companies. I remember Pfizer, Hoffmann La Roche, GlaxoSmithKline at the time, later on Boehringer Ingelheim. Some of those, I don't know if they still exist. Well, and negotiated a differential pricing for low and middle income countries from $20,000 per patient per year to $1,000 per patient per year. And that got the ball rolling. And later on, I think the discussions on parallel importing and the generic production, that we get all the way down to $80 per patient per year for drugs that were much more effective, than the ones, we had at the same time. So he kind of managed, to balance, the importance of R&D, the importance, of the pharmaceutical companies, no doubt about it, but at the same time, a greater focus on equities and access, to medicines to make a reality what we all say. If none of us is safe until we all are. And I think if the discussion continues that we have to put, the waiver on the table, let's put it on the table and discuss it in a constructive way. And I think we are at a time that in all corners, you may find allies of people who want to do good, from business, corporate, pharmaceutical companies, governments, civil society organizations, to engage constructively to find solutions, to that. My last point is that we have just to make sure that the geopolitical or geostrategic location of a crisis or of a disease should not be the most determining factor of the commitment and an engagement and the partnership that is required. And that is something really to bear in mind, that we continue to neglect many of the diseases that can wake up one day and haunt us until it is very close, to our doorsteps. There is a whole baggage, a whole bag full of, what we call neglected tropical disease. And I really hate, that appellation in itself, but we seem even to accept that there is a whole bag of neglected tropical diseases that are there that we are not, touching on, and then they remain, neglected. And then we wait, until there is some one that we consider to be, a kind of a threat, to all of us, and then start, to react. And of course, that is what is creating this kind of a mistrust that we are seeing. And sometimes, when around there, at the community level, and people will ask you very simple but very pertinent questions. Where were you when we were dealing with all these problems that are killing, our children and our under fives? And then now you are coming with and then they say your Ebola, your COVID, your whatever you name it, because that is then what it becomes a kind of a strategic or security threat, for all of us. And I think we have to bear in mind also that what we do not consider to be a threat for all of us today may wake up one day with a combination of demographic pressure, interconnected world, climate change, that is all that what seems to be very far away from us and sort of very close to us. And we should not consider the geo-strategic or proximity, as a major determinant of our commitments. And I think building a health architecture, a global one, that is taking into account of all of that will be extremely important, extremely critical. And we salute, some of those steps that are being done in that direction. So I think it was Paul who mentioned the Berlin Hub. There's the African CDC, doing great work. Now the regional committees and then the regional institutions also building on that we all come together, to have a proper architecture that would address the need of all. Thank you.
Thanks so much, Lars. With that brings us to the end of this fascinating discussion. I'd like to really give a sincere thanks again to Bernhard Braune, Paul Zubeil, Elhadj and Kate Dodson for joining us in this discussion. Thank you. Now, please watch this space for the paper to come out very soon. It's a collaboration between the Global Health Hub Germany and Healthy Developments. There will be future catalyst dialogues of this nature. Here, if you're in the room, we're breaking for a coffee break, and the next session will start at 3:45 on pandemic preparedness and response, as Paul already alluded. So stay tuned for that, or if you're online, take a coffee break, come back for that session to resume. And until then, thanks so much for joining. Thank you.